Dr. Jörn Schattenberg is a professor of medicine and director of the Department of Medicine 2 at Saarland University Medical Center in Homburg in Germany. So that's Homburg, not Hamburg, as many people might think. He's board certified in internal medicine and gastroenterology and hepatology and infectious disease, and his research centers on translational science and clinical trials in hepatology, including EU-funded projects on metabolic liver disease and biomarkers, such as the large Liver-AIM collaboration and also GRIP on MASH. And he's the incoming chair of the UEG Scientific Committee and serves as an associate editor of JHEP reports. And that's just a little bit of the long list of things he's already accomplished. And I also count him among my friends like I do you, Mike. So Jörn, you're going to be speaking about understanding MASLD and MASH and the relationship between primary care and the hepatologist from your unique view. You have about 20 minutes. Over to you.
Thank you, Jeff. Thank you for the kind introduction. Thank you, Michael, for inviting me. It's a true pleasure to be among this esteemed group of colleagues and friends and advocates, of course. To get us started, I will start talking about the understanding of MASLD and the relevant relationships between primary care and hepatologists. MASLD is a part of the disease spectrum you see in your patients that come to your daily clinic with metabolic disease, dysfunction of the metabolism, if you'd like. This is a recent overview by the European Atherosclerosis Society, where you see the statement that metabolic diseases occur as multi-organ diseases. And that's very much true. And I'm here today to tell you to not forget about the liver in this picture of multimorbid patients. And you can see in this recent review, there's a number of things mentioned here. MASLD is coming into the picture. Of course, there are multiple drivers: environment, genes, lifestyle. But as part of that holistic patient pathway, we have to consider liver disease. I'm going to tell you a little bit why I think this is relevant for your practice as primary care physicians. So what is MASLD? It's the metabolism not working right. Sugar and fat metabolism is dysfunctional, and it's associated with fat in the liver, fat droplets. The definition is traditionally defined by histological analysis. We're going to get to that in a second. So fat in the liver. And it's not just the liver. There's coexisting of fat in other organs. The visceral adipose tissue is diseased. There can be pancreatic fat. So fat deposition outside of the adipose tissue is the real issue here for our patients. It manifests in the liver as an inflammatory disease, and it's the basis of organ injury. This is how the pathologist used to look at the disease and define the disease. And you will see that there is steatosis. This is on the right-hand side. You will also see that there are stressed hepatocytes, meaning we have ballooned hepatocytes. That's a specific term the pathologist defined for us. It's also one of the hurdles we're being faced when identifying liver disease. There's inflammation in the liver lobular. And all these three, injury and inflammation driven by fat, produce scar in the liver. And the scar amounts to advanced fibrosis or even cirrhosis. And traditionally, the disease was defined by those histopathological hallmarks. And even today, we're talking about them as disease modifiers and impactors. Now, it's important to realize that it's not the pure presence of fat that makes the difference for the patient, but it's the amounting of scar over time. And the amount of scar, again, traditionally characterized by histological staging after liver biopsy, all the way up to cirrhosis, is the problem that exists for the patient. The fat is the reflection that the metabolism is dysfunctional, but that dysfunctional metabolism leads to inflammation and scar over time. That process, and I'm going to take a little far-fetched analogy here maybe, but it's somewhat similar to atherosclerosis. So we know that certain inflammatory mechanisms from the diseased metabolism results in end organ dysfunction. And I like this cartoon. I'm going to advance my slide. Oh, sorry for that. Okay, I would hope this works. I like this cartoon because there's a redundancy of the pathophysiology. You see on the top cardiovascular disorders with deposition of fat in the endothelium, atheroma building, and then the catastrophe for the patient, unstable plaque with stopping of blood flow to the heart or the brain, giving severe end organ injury. The same the same events are happening in the liver. You see deposition of fat, inflammation, and scarring. And here it's not the blood flow that's disrupted, but the functional capacities of the liver once it's cirrhotic. So the redundancy of the pathophysiology, and the body does that in multiple organs, is underlying the progression to end-stage liver disease. It's very important to recognize that we used to call this disease what it's not. We used to call it fatty liver not caused by alcohol. But there is a lot of inaccuracy in that term, and thus a big nomenclature conference 2 years ago with a global agreement and stakeholder buy-in renamed the disease spectrum, defining steatotic liver disease. And among the umbrella term of steatotic liver disease, there's metabolic dysfunction associated steatotic liver disease, MASLD, and the inflammatory subtype MASH, now positively defining the disease as being driven by the diseased metabolism. And I think for that reason, this is a very good term and a very important nomenclature change. As I highlighted in the beginning, this is not happening in isolation. There is multi-organ interaction. There are important mechanisms from the gut, the liver signaling to the brain, to the pancreas, and extrahepatic manifestations in patients with MASLD. I'm going to show you some of that data. This is derived from a German primary care database. So patients being under care with primary care physicians in Germany under the public healthcare insurance. And you can see the blue group being categorized by having MASLD, and the red group not having MASLD. And you see that over a time frame of 10 years, albeit matching for risk factors at baseline, the blue line splits from the red line, indicating an increased risk of both, on the left-hand side, cardiovascular disease, on the right-hand side, the incidence of cancer. That tells us that adding fatty liver, MASLD, to the picture of a patient increases the risk independently of the other metabolic risk factors. I think that's very important because we'd hope that if we managed MASLD, that risk is then improved. And it's truly happening in subgroups. So patients living with type 2 diabetes have a significantly higher prevalence of the disease, and they have significantly more advanced disease stages. So the subgroup of patients living with type 2 diabetes are really the high risk group. That brings us to the point, well, how to identify patients with liver disease in primary care, because you might say, well, I have many in my practice. Should I be looking out for all of them? How can I risk stratify, and how can I treat the ones maybe in primary care that I can keep, and what are the patient populations I should be referring for additional support testing or specialist management? There are guidelines there. I'm going to be speaking about guidelines in a little bit again, but the guidelines recommend to screen in high-risk populations. And I've just shown you the type 2 diabetes population is at high risk, obesity, the presence of steatosis on ultrasound, and of course, elevated liver enzymes. So there are subgroups, and it's probably a large subgroup in your practice that should be screened according to guidelines. We've gone into a German primary care setting, and this German primary care physician was also a provider for diabetes patients. This is a typical setup in the German healthcare system where you can enroll patients in a diabetes specialist program, the German diabetes program. It might or might not happening in your European country, but you will have type 2 diabetes patients in your practice. And when we looked in that again, this is at a primary care level population. We observed that 10% or even 12% of them were cirrhotic. And the treating physicians were not aware of the underlying cirrhosis. And I think this is an important message. If you go into your type 2 diabetes population, 1 in 10 is going to have advanced liver disease, and you need to identify them. How to do so? The guideline came up with a very simple, very biological, plausible, and cheap test. I'm not considering this a diagnostic test, but a risk stratifier. It's called the FIB-4 index. Take the at-risk population, apply the FIB-4 index, and risk stratify your population into low risk of advanced liver disease, high risk of advanced liver disease, and an intermediate group where you might need additional testing, or you can opt for optimized management and retesting down the line. The FIB-4 is truly a very good test because it's biologically plausible. It includes liver enzymes, platelets, and age. It's easy access and low costs, and it allows you for that categorical assessment according to the categories that I just mentioned, with an absolute strength to rule out advanced fibrosis. As it's not a perfect diagnostic test, we then introduce a concept where we suggest sequential testing and refine the patient population with indeterminate or advanced test results. And why is this so? Because it's the patient population with advanced fibrosis that experiences higher rates of outcomes, death from any cause, and hepatic decompensation. And this data that has been published in the New England Journal is a prospective study. So we know well when we identify the FIB-4 high group, it's the group that runs into trouble, and we want to manage them actively to avoid detrimental outcomes. There are additional non-invasive tests your experts or you might be doing in your clinic. I've mentioned the FIB-4 as a risk estimation tool. There is imaging tools the specialists might use, and there's some diabetes providers that can offer that type of elastography. I'm giving you an example in transient elastography here. And there are other blood-based tests, ELF or an emerging one, Pro-C3 Adapt. They're easy to sample and allow you for additional risk stratification. Let me finish off by giving you an update on guidelines, and I think that's important because you want to work in a setting where there's a lot of evidence and the experts and according to the experts' recommendation. The goal is to identify patients with advanced disease or even patients with MASH is to improve the metabolic phenotype and control the metabolic co-conditions that are happening. We do have MASH treatments available in Europe. EMA approved a drug that is called resmetirom, and it is available in Germany, and it should be coming to your European countries soon, hopefully. And the goal is to reduce the number of outcomes in both liver outcomes, but also cardiovascular and entire outcomes, because in the end, that's going to save us costs and suffering from patients. How to do so? These are the EASL guidelines. They suggest to diagnose steatotic liver disease based on the presence or absence of cardiometabolic risk factors, defining MASLD in the population where there is less than 20 grams of alcohol in women and less than 30 grams of alcohol in men. Working in clinic myself, I know these numbers are pretty abstract, and it's at times difficult to determine the underlying cause. There is the MET-ALD category, but I think as clinicians, we tend to be fairly good, if not but not perfect, in identifying patients that have metabolism driving liver disease rather than alcohol driving liver disease. There are some biomarkers, mostly in clinical trials, but I think we'll have more help in the future. Revisiting the schedule of FIB-4 risk stratification, I've shown you this before. Use the FIB-4 score in your population in ruling out the patients that are of low likelihood of having advanced fibrosis. Manage the ones in the indeterminate or intermediate stage, and you can do so by improving their metabolic control, using a lot of drugs that you have available to treat diabetes and hyperlipidemia, and really look after the ones in the high-risk category because they're at risk of cirrhosis, decompensation, and even hepatocellular carcinoma. How will the experts or how can you manage those patients? I've mentioned the control of comorbidities. There are approved drugs to treat obesity, dyslipidemia, and type 2 diabetes. I've also mentioned the MASH targeted treatment of resmetirom in non-cirrhotic patients. We do use non-invasive tests, so there's no need of liver biopsy to manage any of this. And we use the non-invasive tests, the biomarkers I've discussed, to more or less also to set the indication for treatment and to monitor the patient under treatment. So good news, a lot of the liver field has been shaken in the past by having to do liver biopsies. If you're a liver patient, you might have undergone liver biopsy by yourself. We're using non-invasive tests today. Let me wrap up before I hand back to you, Jeff. Take-home messages. There's been a nomenclature shift that defines the disease positively based on the underlying pathophysiology. And I think MASLD is the term moving forward and it's been so for the last years. Patients living with metabolic liver disease have cardiometabolic comorbidities that should be managed actively and according to guidelines. This is an area where we have an intersection and work together with cardiologists, general care practice providers, and of course, allied health professionals giving guidance on, for example, nutritional and lifestyle. For sure, fatty liver disease is underdiagnosed. In the past, there was not much to offer to these patients, albeit some words of advice. Today, we can treat them, and importantly, we can influence the deleterious cause end-stage liver disease can take. There's strong support to do so by national and international guidelines that recommend screening in high-risk populations. And I've mentioned the FIB-4 score before, and I'm going to do it again as a risk stratifier. It's not a perfect diagnostic test, but it's a very good and cheap risk stratifier, and it helps you to manage your patients according to their risk. And why should you do so? Because treatment options are available. And with that, I'm going to finish this presentation, stop presenting, and back to you, Jeff.